Perfect. Okay. I think I have everybody's attention. Hi, and thank you so much for spending a few minutes with me of your lunch break. My name is Cynthia Gneco. I'm here located at the Holy Cross Clinic in the General McMullen, right outside the west area of San Antonio. And I've been here, just to give you a little bit of a background, since May, mid-May this year. And I'm an internal medicine geriatric trained. I initially was working in the south side, and now I moved into the west side. So I'm very glad to be working with HealthTexas. So today we're going to just glimpse about, the general knowledge and general information about sleep apnea, and not only how can you prevent it, but mostly how can you manage and hopefully get cured or get better with it. So that's the topic of today. Oh, sorry. Oh, apologize. Okay, perfect. So would you do that? Okay, thank you so much. So the definition is, it's basically sleep apnea has the name. It says apnea is basically stopping breathing. It's an absence of the breathing. It's a condition that makes you stop breathing in the short periods of times during the sleep. It can be divided in two, or there are two classes. The obstructive, which narrows down with a throat narrows or closes, which most of the people that have sleep apnea has the obstructive type, or the central sleep apnea. It's basically that your brain doesn't give the signal correctly to the muscles to breathe. Now, when we sleep, we're unconscious. So that breathing pattern, we do not control it. The brain takes over. So most of the time, what we see in patients with obstructive sleep apnea is referred as the obstructive one. The central one is very rare. It's mostly common in persons that had stroke in that particular area of the brain, or for instance, that have diseases like Pick disease and so forth. Most of the time, they do not know they have it. Most often it's the partner that recognizes the fact that, oh my gosh, you're not breathing during the night, or either you snore a lot. Unfortunately, it affects over 17% of the general population, more men than women, and it's most commonly on overweight, obese patients. Now, anatomic factors, because it's an obstructed, most commonly it's referred as obstructive sleep apnea. It has to be a lot with the obstruction in the windpipe from the mouth up until the beginning of the trachea here. It can be caused by enlarged tonsils, most often than not in kids, the volume on the tongue, soft tissue enlargement. There's some people that have a lot of gums, a lot of mucosa around the opening, lateral pharyngeal walls, length of the soft palate, and abnormal positioning of the maxilla. If you see the drawing, the upper one is the normal sleep, the way that you are supposed to. And the second one, the tongue is very large, the soft palate, which is right on top of the dingly thing that is on the back of the throat, the uvula. And when those things are enlarged, it can basically obstruct because of gravity. It just falls back. Next one. So in this chart, basically what it tells me is that, okay, so I do have it, what can cause, what can this affect to my body? Essentially, it creates what we call hypoxia, of lack of oxygen. Whenever there is an intermittent hypoxia, because it comes in waves, in period, not only it affects the sleep, or causes a sleep fragmentation, how we call it, but also there's some chemical being released. There is a lot of sympathetic activity. Sympathetic activity refers to when you are excited, you release cortisol, you release adrenaline. So all those things, when that releases through the body, what it tells the body, hey, I'm awake, I'm in action. So let's get all of the substrate, all the food in the bloodstream so the brain can work better, because there is lack of oxygen. That's the interpretation of the brain. So what it does is it releases fat from the muscle, fat from the liver. The cortisol has the name, let's say, we're stimulating not only the pancreas, but also the liver to secrete more insulin. So there is a lot of diabetes, as you can see there, increase in these patients. The leptin resistant, leptin is the hormones that metabolizes, or in other words, creates the balance between the insulin and the blood sugar. So we see a lot of patients that develop diabetes or are uncontrolled diabetes because of it. Whenever the cortisol is high, cortisol can create secondary hypertension. So we see a lot of patients that have uncontrolled high blood pressure, and it's mainly because their sleep apnea is not controlled. So it's not only the sleep, it can affect a lot of components in the body. The non-structural risk factors could be, as I mentioned, obesity, most particularly in men, whenever the neck size is more than 17 centimeters of diameter, and the woman is a little less of 15. Central fat distribution, when there's a lot of fat tissue around the belly and the hips. As I mentioned, the male-female ratio is 2:1. Advanced age, postmenopausal, alcohol abuse, medication like sedative, like benzodiazepine, Valium, Xanax, smoking, supine sleep position, sleeping on your back, and the abnormalities in the REM or rapid eye movement sleep. So excessive daytime sleepiness, I just wanted to point that out. Because the main symptoms of the sleep apnea can also refer to daytime sleepiness as one of the risk factors. The main symptoms are loud snoring. You might not even recognize it that you have it, but your partner will. Being tired, especially in the morning. Daytime sleepiness, and other symptoms might include waking up joking or gasping, morning headaches, because remember, your oxygen will drop, your respiratory drive will slow down. So what will happen? You will start to accumulate CO2. CO2 in the brain creates headaches because it's a vasodilator. The same thing happens when you have a monoxide intoxication in your house or you have a lot of CO2, you will have headaches. Waking up in the middle of the night, nocturia. Waking up feeling unrest or groggy, trouble thinking or clearly remembering things. As far as the daytime symptoms are not restorative sleep, I mean, you go to bed at 10, wake up at 7, you're supposed to feel rested, but you don't feel rested because the quality of the sleep is not 100%. You get headaches in the morning, dry sore throat, daytime fatigue, cognitive deficits because you don't let that memory being stored in the hypothalamus where it's supposed to because your brain is still working because of all the enzymes that I mentioned before. Personality and mood changes, GERD or reflux, decreased vigilance, hypertension, being resistant to treatment, depression, sexual dysfunction. Now, how do we evaluate this? There are a lot of scales, there's a lot of questionnaires. The most commonly used is the Epworth sleepiness scale. I didn't even put it here because it's literally like 20 questions. But basically when you score more than 12, you have a greater propensity to fall asleep in the middle of the day. And not only is diagnosis, but it's a clinical tool that will help us to reevaluate in phases. For instance, you were diagnosed with the sleep apnea now, you get your CPAP in 6 months, and then in another 6 months, I will do the scale, the Epsom square, Epworth sleepiness scale, and then that number should drop. You should see a response. This one mentioned before. So basically the intermittent hypoxia, patients will have obstructive apnea can create problem with high blood pressure, heart failure, cardiovascular disease, and diabetes because of the reasons that I mentioned earlier. So how do we define it? There's different scores or index that we do. So in a period of 1 hour, whenever you have more than 5 episodes of not breathing for at least 10 seconds, that's defined as having a high AHI or apnea-hypopnea index, the next one. So as you can see, we rate those things. And the way that we rate those things is with the sleep study or pulling sonogram that we do. It's that overnight study that usually done in a lab. They connect you with different things. They connect you with the EEG, with the EKG for your heart, some electrodes in your limbs to measure the evokes or EMG or what they call electromyography study. They do a pulse ox. So there are at least 5 or 6 characters that they measured And what they do is that they measure that index, how many times you stop breathing for at least 10 seconds within an hour. So less than 5 is normal, 5 to 15 is mild, 15 to 30 is moderate, more than 30 is the severe. As I mentioned before, you have to have A or B plus minus C. Excessive daytime sleepiness, the first one, we measure that with the scale, the score that I mentioned before. You have to have the symptoms. Go ahead. And then the C is the overnight monitoring or their sleep study. So 2 out of 3 of those things are clinical, are things that you're telling me that you have, the symptoms, or that you feel the Epworth scale that is being positive. And the third one is the sleep study. So that being said, unfortunately, it's very prominent in the population, but we don't diagnose it. It's not being that much of a diagnosis whenever you come, because some people say, well, I get older, I sleep less. No, when you sleep, even though you get older, because you get less amount of hours in your sleep, you should feel rested in the morning. Feeling tired just because you're older in the morning is not normal. So that's something that we as providers, medical professional, don't ask enough. In the geriatric population, I'm a geriatrician, whenever we do the geriatric assessment, the one that we do every 3 months, sleep is a big topic because it corroborates with high blood pressure, diabetes, dementia, all those things that I mentioned before. So again, how do you do the diagnosis? The scale, the history, and the sleep study. So the polysonogram is the fancy name for the sleep study. It mentioned, as I mentioned before, respiratory effort, an EKG to see how your heart is behaving, your body position, whether or not you're snoring, whether or not you have some leg movements, some abnormal eye movement, cheek movement. So you're hooked up to a machine. I don't know if you've seen that before. You basically look like a robot. And they hook you up to all of these things. And I just wanted to bring this so you kind of see how we looked at it. The specialist is the one who reads these things, but whenever you see a pause, that's not normal. And in the bottom is the seconds. The upper one is the EEG, it's measuring the wave in the brain. And the bottom one is the EKG. So there is another study that is also done whenever you're in the sleep lab, and they measure the sleep onset latency. So the sleep latency is a term that is defined by the length of time that it takes for you to being in bed and actually falling asleep. The normal time is 10 to 15 minutes. Anytime we see somebody less than 8-10 minutes, like literally you're talking to them and all of a sudden they just fall down asleep, that could be one of the signs of narcolepsy. I don't know if you've seen people in the office or when you're on a regular living, they're waiting in the doctor's waiting room and they snoozed out right away and in 1 minute and they're actually snoring and dreaming. That is not normal. So the treatment for sleep apnea, depending on the severity, depending if it's mild, depending if it's moderate or severe, we have different tools. The most common tool is the CPAP, or the continuous positive airway pressure. Basically what it does is, because it's an obstructed disease of the windpipe, it basically pushes air at the time that you exhale. So it's right after you finish exhaling, it pushes air, so the airway will be always open and there will be air coming in. Whenever you have a mild or your AHI score less, less than 10, we tend to use more oral appliances. I don't think you've seen it. It looks like a grinder. What do they call that? It's a mouthpiece, it's a plastic, and you basically insert it either in your mouth or there's ones that you put in the top of the nose, and it basically will expand the area in which the air will come in. Whenever you see a score more than 15, that means that you have moderate to severe, so we use the CPAP. And that is ordered by the pulmonologist or sleep medicine specialist. So different advices that we give the patients that were just recently diagnosed with sleep apnea, or they think they might have sleep apnea. Obviously, look for your primary care physician or an specialist help. Adjusting the sleep position, basically stay off your back, sleep on your left side. If you have reflux, it's better for you to sleep on your left side because the bottom of the stomach would go down. Now, this is really difficult. Some people move around the bed. They basically lay on the right side and the next morning they're in the right corner. If you're obese, overweight, definitely lose the weight. I've seen patients that were diagnosed with severe apnea and they lost 30, 50, 60 pounds, and boom, they don't even need the machine anymore. So that's great. Avoiding alcohol because it can make a sleep apnea worse. Why? Because it does affect the sleep latency, okay? You might be able to fall asleep quickly, but the quality of the sleep is not the same. Some patients, especially older patients, like to have this nightcap, a little whiskey, a little hard liquor. It helps me fall asleep. Yes, it will help you fall asleep, but you will not feel rested in the morning because the quality of, or what we call a sleep efficacy, is not 100%. As I mentioned, there are some dental devices that you can put in the jaw and the mandible inside of the mouth. That's one example. And the last thing that we go to is the surgical resources. Whenever either the CPAP or those mouth appliances does not work, we refer them to either maxillofacial or ENT. And they can take the uvula, take a part of the soft palate, take part of the mandible, of making sure that it's a little open when you fall asleep. And those are the names of it. I just wanted for you to know that there's another option. And even though that is very aggressive, we don't go through that route, but there are other options. And that's it. I just wanted to keep it short because I'm pretty sure that you have some questions. And sleep apnea is one of those topics that you can go branch out. This is the basics, but it definitely is helpful to know and maybe recognize whether your loved one or yourself will have it in the course of your lifetime. Because as I said, the prominent level, a number of percentage of people that have it is 17% in the regular population. And thank you so much. I don't know if they have questions.